Hi, this is Fernando Gomez Sancha, and I want to share this live case that I did for the BAUS Congress in Manchester, sponsored by Cook Medical and moderated by the great Leye Ayay. So I hope you enjoy the case.
Hello, good night. I'm going to introduce Dr. Gomez Sancha. This is a lip surgical transmission, and the case is an Bloc HoLEP with virtual basket, and the laser settings were 2 joules with 50 hertz and magneto 1 joule 30 hertz. Well, the clinical case was a 74-year-old male with type 2 diabetes, hypertension, hypercholesterolemia, frequent sciatic pains, and medications was tenolol, pregabalin, and olmesartan. Hemorrhoidectomy, and he was ex-smoker. The patient presents with lower urinary tract symptoms, suggestive of BPH, an ultrasound with 85 trilobar prostate, and a normal digital rectal exam. Qmax was 4.3 and interrupt flow and 20 residual time of personal urinary leakage. The curable PCA, he had a gradually augment of 58, and periods were 73, periods 1 and 2, and with a volume 73 and 67 and 88. The technique of Bloc HoLEP, we initially with a progressive Bloc bilateral, and we dissect. Then we did an early apical release and preservation of filter mucosa, and circumferential dissection and Bloc enucleation, hemostasis, and morcellation of prostate.
Okay, hello.
Hello, Fernando. Finally.
Hi, how are you?
Good evening. It's Leia here. How are you?
Fine, fine. Can you see
Excellent.
the endoscopic image?
Yes, we can see it. We
Okay.
saw it. It's disappeared. We did see it a second ago, but you can still hear me. So just on behalf of everybody, just thank you so much for taking the time to join us today. I'm aware it's probably, 9 o'clock in Madrid. This is your 10th HoLEP of the day, very likely. So thank you for taking the time to join us today. So we've heard the history of the patient. So please, over to you, please. Thank you very much.
Okay, but confirm that you can see the endoscopic image. Can you?
We certainly can. Loud and clear. We're clear for takeoff.
Okay, so let's start. As you can see, we can see the edge of the sphincter here. This is the sphincter. This is the edge of the apex of the adenoma. So I'm going to mark the white line, which is going to serve as a reference. You see, HoLEP. I know that HoLEP is very, very developed in the UK. There's many people nowadays doing HoLEP. But of course, there has been a lot of black legends with HoLEP, in terms of the danger of the technique. It could become risky. I mean, people were afraid of developing serious complications during surgery. And also, there was a fear for incontinence. So I have to say that things have changed a lot. And our understanding, well, we have had two main improvements, I think, in the last years. One has been the technological improvement. And as you can see, we are using now all these sophisticated pulse modulations like virtual basket and magneto, etc., that are giving us much better hemostasis, especially the first pass hemostasis, which means that when we are dissecting, as you can see, we can have excellent hemostasis at the same time. Also, morcellators got better than the old-fashioned VersaCat morcellator from Luminis. But also technically, we have understood a little bit better how to preserve the sphincter function. So now in our center, the rates of stress incontinence are very, very low. And I think people that are starting to realize that you have to be careful with the sphincter mucosa to preserve the sphincter mucosa allows you to obtain much better continence, immediate continence results. So here, what? Yes, go ahead.
No, please carry on.
Okay. So what I'm doing now is developing the posterior plane. I tend to think of the adenoma as if it was a box, you see. So I'm going to talk about the posterior plane. I'm going to talk about the lateral planes, and I'm going to talk about the anterior plane. And here I am developing a little bit of the posterior plane. Normally, we're going to have some lateral fixation. So there is a limit to how far you can take this posterior plane. In my understanding of HoLEP is that we're going to sequentially mobilize the adenoma by separating it from the capsule. And it's going to be a strategic, let's say, sequence of events, because we want to mobilize the adenoma to get access to places where you cannot have access at the beginning. It's like visiting a palace, you know, when you visit a palace, you open one door, you enter a room, and then that room has another door, and then you enter the next room, you know, and so you need to unlock, let's say, or you need to mobilize to be able to reach places with minimal tension, with minimal trauma. So this would be the posterior aspect. One thing that you can notice immediately is that I did the white line in about, I don't know, 1 minute or two, and
Absolutely.
then right away I started enucleating. Now I'm going to do a little bit a deepening of the white line here, so we can come up.
Can we see the endoscopic? Can we see the endoscopic view, please?
¿Podéis poner la visión endoscópica, por favor?
Thank you. Thank you.
No la quitéis en todo el rato, no es tan importante, no la quitéis nunca, sorry. Yeah, they tried to show my hands, so no. Do you see them now?
Yes.
Yes.
We see the endoscopic view. That's fine.
Okay. So you see, what I'm trying to do now is I'm going to ascend in one side from 6 o'clock to 12 o'clock, towards 12 o'clock. But you see, the problem with incontinence in the classic way of doing HoLEP was that people would do this encircling technique. So you see, you would be here and you would try to go all around the adenoma to get up to 12 o'clock. But this, you see, the problem is that here there are still attachments. So if you go in here and you try to dissect up, you're going to pull from this attachment. So in my conception of HoLEP, I think you need to come further down to release these apical attachments first, you see? So because when you...
Is this what you call early apical release of this area?
Yes. This is, of course, it's not an immediate apical release, but of course, I'm doing a progressive mobilization of the apex. I start, you see, posteriorly. This would be now my lateral line. Remember, I think of the adenoma like a box, so it's very easy to understand. Then we would cross over to connect. You see, I want to connect because another detail that is very important in this operation is to follow these very long lines. You see, I am doing very long movements. So I'm going from, you know, below here all the way up. I don't do this. If you do this, you're going to get deeper here, but here is not so deep, and here is not so deep. So you get an irregular line. But if you do very wide movements of dissection like this, you see, we will always have a nice orientation system. To me, this is my GPS for HoLEP, you see.
So Fernando, you make it look so easy. So thank you for that. Question, we haven't really talked about your settings, your laser settings when you're doing HoLEP. Could you just educate us on that, please?
Okay. You know that the classic HoLEP would emit a single pulse each time. These pulses are delivering high energy that has a high affinity for water into the water. So the water gets super hot. This is a state of water that is called super hot water. And the super hot water will experience what we call explosive boiling. You know, when you heat so suddenly with one of these high energy pulses, this explosive boiling is going to generate this famous bubble. And the bubble is going to generate some pressure wave because of the expansion of the water. And then, of course, if you think about it, I'm using 50 pulses per second. That means that we're going to have many, many bubbles trying to expand in the interface between adenoma and prostate. Okay, so that's going to dissect the plane. So basically, holmium laser behaves like a pair of scissors that is opening, you know, the scissors to dissect. That's why when I fire between adenoma and capsule against the line of dissection, you can see that it opens up very nicely. But of course, the problem with the classic HoLEP was that, you see, I'm reaching the 12 o'clock area here in this side. You see, I dissected. Now I'm starting my anterior line here. So I'm going to go a little bit more anterior just to let the tip of the adenoma drop a little. Okay. So we get some space. So with virtual basket and MOSES, you know, this double bubble pulse modulations, what we can get is an initial pulse followed by a second pulse. So when the initial pulse generates the bubble, the second pulse is going to travel through the bubble and is going to reach a little bit further. The problem with the classic holmium was that it was very difficult to achieve a dissection effect, which could give you a simultaneous hemostatic effect. So many times you would dissect and then you would go back to try to coagulate a little bit. But here, as you can see, with this double pulse, we can get very nice first pass hemostasis, which is amazing because, as you can see, I'm concentrating on working. I don't need to concentrate too much on hemostasis. Okay, so here, look that I mobilize the posterior and lateral aspect a lot. I think when you work in the posterior aspect, the sphincter is not suffering a lot. So now I'm following my white line to come up. You see, I deepen the white line a little bit initially to get a good view of where the plane wants to go, you see. And then I'm going to climb progressively. You see, I go from distal now to more proximal, trying to capitalize the, let's say, liberation of the apex that I have done up to that level. You see here, I don't go further up because I notice here there's still attachments. So I come out, cut the attachments. You see, following this white line. Sorry for the.
So Fernando, we were talking earlier about laser technology, and you mentioned about virtual basket for HoLEP. What about TFL technology for HoLEP? What are your thoughts?
Okay.
What about your thoughts on thuleps?
Well, you know, thulium lasers were here before thulium fiber. Initially, we used them as a continuous wave laser, and then they managed to get some pulses. You know, even with let's say thulium yak crystal, you know, as the source of the laser energy. And these pulse lasers are much longer than the holmium pulses, which means that if you're going to fire 2 joules in one pulse, it will take much longer to deliver the energy to the water. So basically, the bubble that is going to be producing is much smaller. So the effect of dissection, you know, like this scissors opening, you know, that we were mentioning before, is going to be much less. Let me stop for a moment to tell you, you see here, we have this plane on one side, and this side, and we have the other plane on the other side. So now we can cut and connect at 12 o'clock, you see? So now this is the end of the early apical release, as you can see. And now I'm going to try to work a little bit on my anterior line, because when I manage to have a continuous line anteriorly that connects very nice from one side to the other, we will have a fantastically easy, you know, rest of the work, rest of the job.
It'd be nice to see your hands whilst you're doing this, whether you're upside down. Can we possibly see Fernando's hands?
Yeah, podemos mostrar las manos, las dos imágenes, no se puede. So briefly, they will change for a moment.
Okay.
You see, so my hands This is a 12 o'clock fiber, keeps the endoscope very easy to manipulate. And I like to hold my fiber. Let's change back to the, vamos a cambiar otra vez a la imagen endoscópica. I like to hold the fiber like this because, as you can see, the movement of the scope is very simple. You know that the instruments we're using for enucleation are certainly modified resectoscopes, which means that, many of these instruments come with a trigger. And many people, when they get the trigger, they will automatically, intuitively use the resectoscope the laser cystoscope as if it was a resectoscope. And if you think about it, when you have a resectoscope in your hand and you're working at 12 o'clock, the resectoscope is upside down. Yeah. When you work at 3 o'clock, the loop rotates, so it faces 3 o'clock and then 6 o'clock and then 9 o'clock. So when you see a surgeon using a trigger for HoLEP, you see that he's moving his hands a lot. He has to raise his arm. So ergonomically, it's much more uncomfortable. So I love this way of manipulating the fiber. It's very simple. And I like simplicity, the less is more principle.
I mean,
so going back to your question before, I think the problem with thulium-based lasers, either solid state, lasers that are produced with a neodymium yak crystal, or the thulium fiber laser, is that they don't have this beautiful dissection effect. You see, the plane opens for me, or let's say the energy is looking for the path of least resistance, which is normally the anatomical plane. So with thulium, you have a much better cutting tool. The hemostasis is super, it's fantastic, but often you're going to cut into the adenoma, and often you're going to cut into the capsule. So I find it much more difficult to use. Of course, surgeons can compensate for the defects, of their instruments. You can enucleate with a spoon if you want, if you give me a spoon, I can do this operation.
Yes.
You know what I mean? So I did it with green light laser. This was a mechanical dissection. We can do it with bipolar. We can do it with everything we want. But of course, if you want to learn, I think probably a holmium laser is the best. Look at this. We're reaching the bladder neck.
Yes, you're almost there.
This is what I call the baleen sign. The whale mouse. Because have you seen these baleen whales mouse? They have a lot of little tools, let's say, like this. So basically, what you see is the circular fibers of the bladder neck, and below them you see the vertical fibers. Okay, this is the pathognomonic sign that you're going to enter the bladder. Here we are entering, and I'm following the shape of the bladder neck now. And you see how easy this is. It's becoming
very, very quickly done, Fernando. You're using the magneto laser.
Yes.
You want to talk about that settings for a second? About the actual magneto settings? Obviously, you're using virtual basket at the moment, and this prostate is behaving beautifully. There's no bleeding at all. There's minimal hemostasis required. When do you switch to the magneto setting?
Well, there has been a little bit of cross-pollination between lasers because, holmium was not perfect for stones. It couldn't achieve the pulverization effect that you can achieve with the thulium laser, but it was very good for enucleation. And of course, lasers are improving. Thulium lasers are improving to become better tools to do enucleation. For example, there are now some companies providing thulium lasers. Here, I'm revisiting the plane, you see? When I see this yellow tissue, I try to go a little bit deeper to find out if I'm leaving some adenoma. Sometimes you're going to find that, you see, when you go a little bit deeper, there's not much danger, and you're becoming a little bit more radical, trying to remove all the adenomatous tissue. You see the plane down there looks a little bit thin, but I think it's a good idea to revisit the planes. If you get too deep, then of course there was no need to revisit so much, and then we can go back to what we had before. But I try to be as radical as possible with these enucleations. So, as I said, there has been cross-pollination, and some thulium lasers are getting slightly better. They manage to have a little bit more peak power, with every pulse. So they get a little bit bigger bubble, and that way, they try to improve the enucleation performance. And of course, Holmium also has tried to adopt some of the advantages of thulium-based lasers, like with Magneto. Magneto emits a longer pulse. So it's not very practical to perform enucleation. I'm not a believer in low power enucleation. I think high power.
I don't think we've talked about your actual settings yet. So what joules and hertz do you use for your HoLEP, and what is your maximum power?
Well, I use 250, which is the classical setting, but I think settings are very important with tones, but not with prostate. Right. I think it's not the fundamental, because you see, with the same settings, if I fire away from the tissue, there's no effect.
It's pointless. Yes, you've got to be on.
So you see, the surgeon has to manipulate the energy, and he has 4 things that he can modulate. One is going to be the working distance. You see, if I get too far, there's no effect. If I get closer, there is some coagulation. If I get closer, there is some dissection. Of course, I have to move the fiber from side to side. This is the second factor that the surgeon has to use. How fast do you move your laser? Because if you fire 50 pulses per second and you move 1 centimeter in a second, you're going to fire 50 times in 1 centimeter. But if you move, let's say, 2 centimeters in 1 second, you're only going to deliver 25 pulses. You know what I mean? Yes. So the speed of movement is going to give you hemostasis, better or worse hemostasis. If you go slower, you will get better hemostasis. If you go faster, of course, you will dissect faster, but the hemostasis will suffer. So this is what I call the tempo of the operation. You need to choose your tempo, like in music. And usually I like the andante or allegro sometimes, but allegro ma non troppo, you know what I mean?
Yes.
So there we are. And the third factor the surgeon has is where to fire. You see, if I fire against the line here, I'm going to deepen very fast into the capsule. Right. When I was near the apex, the fiber is parallel to the tissue, so it's very difficult to perforate. But when we get closer to the bladder neck, the fiber gets perpendicular. You see?
Yes.
So the idea is to fire a little bit more on the edge of the adenoma. You see, when I fire close to the edge of the adenoma, the energy, the energy is staying more on the side of the adenoma. It's not so aggressive against the capsule, okay? And that allows me to work in a very thin plane with a lot of safety. And then there's another factor which is fundamental that the surgeon has. I always talk about the 5 factors. One is the settings, the other one is the working distance, the other one is the speed of movement. Then we have the targeting, and the final idea is that you can fire from very far away like this, you see, but there is no tension on the line of dissection.
Right.
What I try to do is I try to get closer to the tissue with the tip of my scope, and then I generate some tension, you see. So this is probably the most difficult. Yeah, it enhances the effect of the laser to dissect, you see. And here I am in the posterior.
A form of traction, would you say?
Traction and counter traction. Yeah, you generate traction and counter traction. Let's go in to check where's the UO. Normally it should be very close. Let's see. Hopefully here. Huh? So now the edge of the bladder neck here is quite safe. So I'm going to mark it even further here. Notice that I brought my fiber to 6 o'clock momentarily, but then I will go back to 12 o'clock. What I don't like is when people work like this, because they have to move. You see, they combine 2 movements, a rotational movement and a displacement movement. And I only do the displacement. It's a very simple movement when you keep your fiber. So we're nearly finished.
On the lateral side, though, how do you avoid that movement on the lateral side?
Oh, no. I keep my fiber always at 12 o'clock.
12 o'clock.
Yeah, I start at 6 o'clock, and many times I finish at 6 o'clock. You see, now I think I can probably lift up the adenoma a little bit here. Lift it and then push it inside the bladder. Let's see if I can flip. You see, some people say that when you do en bloc, sometimes the prostate is bigger than the bladder neck. But you see, we can flip only one side. This would be the prostatic urethra, and this is the bladder neck. And then you see, we go to the other side, we have much more space to finalize the dissection. You see here, I'm going to fire close to the edge of the adenoma, so I don't deepen. I don't want to go there. I want to stay inside. And you see, these strategic steps allow you to work continuously. When you work continuously without stopping all the time, you make a very fast operation. And you are fast because, not because you're running too much, but because you are constant. And then you see what I'm going to do is I'm going to continue the rotation. I have rotated.
Very efficient with your.
I can hear you, but I lost some words.
Bravo.
So this is bladder neck now. You see, I need to. I'm not listening to everything you say.
Your Wi-Fi. So we're losing momentarily. Maybe a Wi-Fi.
Maybe it's a Wi-Fi issue. I don't know.
No, we can see you now. We're back. We're back with you.
We're back. Okay.
Live.
So here again, I'm checking the UO. I'm going to mark a little bit the bladder neck here. So we are quite careful. Okay. So here, this is the end of the enucleation. I see under 30 minutes. And you see the paradigm of enucleation has changed.
Incredible.
I'm missing you. I'm losing you.
No, we're here.
So
we're here. Everyone's just admiring your work.
Thank you. Thank you very much. As you know, I was a senior registrar for Professor Mundy in 1999.
Yes, indeed.
And that was an amazing experience for me. And I admire the British urology and the way of thinking and I don't know, there was magic there. I admired the sessions and everybody had such deep knowledge. So for me, you can understand it's a great, great, great pleasure to be able to, let's say, pay back somehow and share. And so this is magneto now. I'm going to use some of this magneto. You see,
And
often when you look...
Can you tell us what your settings are for your magneto setting, please?
I'm using 1 joule and 30 hertz. You know
1
that
joule.
you can... Yeah, you can only use 32 watts.
Maximum, yeah.
So maximum. So I'm using 130, which is very similar to what I was using before for coagulation. And I'm paying now attention to the mucosal edge. You see, one of the disadvantages of holmium is that it doesn't cut like the thulium laser because there is a nearly continuous source of energy coming out of the fiber, quasi-continuum. Holmium is these very aggressive pulses. So when you cut with holmium, it cuts by disruption. Go ahead.
Fernando, you were saying about admiration for the UK system. I think it was very different in your days compared to now. I mean, there's a big drive for us to send patients home in keeping with GERF, which is get it right first time, try and do day case HoLEPs. Do you ever bother with that in Spain, in Madrid?
Well, in my particular case, we do the operations in the afternoon. So we start at 3 and we finish at about 10 p.m. here. This is our, time for operations.
Is that because you have late nights or any particular reason why you're starting at 3?
We got here to the hospital late, and so we don't have the rights, the acquired rights that other surgeons have. So we have organized our activity, to operate in the afternoons. So we have clinics in the morning and then operations in the afternoon. So basically, we leave the catheter overnight, and then in the next morning, the nurses will remove the catheter. But first, they will do a nice washout of the bladder. They will remove the balloon. They will remove the balloon, and they will do a washout of the fossa also. And then they will fill the bladder with saline, probably 250, 300, depending on what the patient tolerates. And then they remove the catheter. So the patient pees the first time very fast. Yeah, right away. And then we give them 20 milligrams of furosemide. This is like the fast track way to send them out of the hospital, probably around 12 or 1 the next morning. Most of the day case operations and centers are sending the patients home with a catheter in the same day. And then,
Indeed.
of course, they bring them back probably the next day or 2 days after to remove the catheter. So I think for us, it's working quite well. We operate in a private hospital, so patients do not want to be pushed out of the hospital too fast, with a catheter. So for the majority of them, having the catheter removed before going home works very well. So this is how we do. But of course,
And if you've done if you've done a very large enucleation, the balloon of your catheter, do you inflate it? You still just do about 20 or 30 milliliters in the catheter balloon.
Well, I tend to adapt
300 gram prostate.
Yeah, I tend to leave a little bit bigger balloon, maybe 50, 60 in the fossa to prevent clot formation and also to allow the capsule
50,
to
60,
contract,
yeah.
maybe.
Yeah.
And in the smaller prostates, maybe I use 20 or 40. So I tailor the balloon to the size of the bladder neck. Ideally, I would like the balloon to keep in the bladder neck, on the bladder neck. But so here we are. So I'm going to morcellate.
So before you start morcellating, you've done a beautiful enucleation. Are you okay to field some questions from the audience?
Yes, go ahead. Go ahead.
Does somebody have any questions for Fernando? Well, there's a question. Would you inflate the balloon inside the prostatic fossa? I suspect the answer to that will be yes.
You can,
Or
of
not.
course. I mean, the thing is with this amazing hemostasis, the balloon has less importance than with TORP, I think.
Okay.
Very rarely we need to put a traction or anything like that. So it really, I think, doesn't matter too much. I prefer to leave it in the bladder neck because mainly the possibility of bleeding is in the bladder neck mucosa. So if you have the balloon there, maybe it will stop.
Any other questions from the audience? I think they're all in awe, Fernando. You've done such a beautiful enucleation. There's a just 1 second, please.
Okay.
So, question from the audience?
I was going to ask about the kit you use. Is it a 26 French resectoscope, or are you trying to do more minimally invasive? And what are your thoughts on that? Thank you.
I hope you heard that question, Fernando. Was that a 26
regarding the size of the endoscopes? Yeah.
Yes, please.
We have a 26 French and a 24.5. We have tried the HoLEP also, and I have to say it's very interesting. But I think we have lived through something similar with stones, and you know much more than I do. With the miniaturization of the nephroscopes, and you went from mini. How do you say this?
Miniaturization.
Help me here. Of your nephroscopes.
Mini. There's
mini perk.
There's ultra mini. There's super mini.
Ultra mini, super mini. Exactly. Yeah. And then, of course, after the initial hype, everybody became a little bit more conscious, and then probably you tailor the size of your instrument to the case, no? So I guess the 22 French endoscope from Figueiredo is very interesting. Very interesting. The vision is fantastic. But then when you want to use the morcellator, they have a fiber optic nephroscope, and the view is not so good, you see. So I find that the endoscope is amazing for enucleation, and I think you probably could do most cases with this 22 French size. But the morcellation is not completely, let's say, achieved yet.
So
So
I'm not sure where you were there in Beam when
Yes.
Felipe from Brazil presented his series on 22 French, and that was very impressive to see because they've miniaturized what they do in his
Yes.
series in Brazil.
No, I agree. It's an amazing contribution, and I think the way Felipe puts it is very convincing because he tells his patients, this is a 26 French endoscope, this is a 24, and this is a 22, and this is a 18. Which one would you have
Which
to
one do you
be
like?
to introduce in your penis?
Yes, they
You
go
know,
for the
so
smaller.
he's very convincing. He's very convincing. But I think when you're trying to do very large prostates, probably still the rate of incontinence we get. I think we finished. So I'm going to get out. You see the morcellation doesn't irrigate properly. So we tend to see a little bit of bleeding at the end. And I'm going to put a catheter and get on with you to answer some more questions if you want.
Any other questions from the audience whilst we have So how long do you keep your patients? You said they go home the next day or do you keep them for a couple of days?
No, they go home the next day.
And
we have we have a 5% retention rate. And then these patients either go home and come back later on during the day. Okay. And often they cannot pee very well, and we put a catheter again and leave it for another day. And then some of them stay and some of them go. I think the mean time that we keep them in the hospital is a little bit less than 24 hours.
Okay.
Regarding this is you can see the urine coming out. There's very little bleeding.
It's nice and clear. It's excellent. Fantastic.
We will leave an irrigation that the nurses will tailor also overnight. That the nurses in the night shift, they always want to keep the irrigations very slow. So that's not a problem. You don't need to tell them.
Okay.
And
Amelia.
Yes.
Yes.
Hello, Fernando. Great to see you here live. I'm Amelia. And I arrived late, so I missed the size of this prostate. But if you had to say for the learning curve, how long would it take? How many cases would it take for a new beginner to get to a medium-sized prostate?
Well, you see, the learning, it depends on how you learn. I think the mistake before and the problem before was that there was no video footage to look at. You would visit someone, but you could see 3 cases, 4 cases, and then you would try yourself. It was not so common to invite someone to help you with your first cases, and it was not sustainable. You could have someone in the first cases, but maybe he wouldn't come anymore, and then you would be left alone with minimal knowledge. So if I train my residents, they see probably hundreds of cases. And then what I do is I do the apical liberation and I leave them to finish the case, which is very safe for the patient. When they get good at that, then they start doing the apical liberation. And I have to say that, for example, Moises Rodriguez Tocarras, my colleague, when I taught him HoLEP, I helped him for 6 cases. And then he flew alone. He's had very good results, very good learning curve. He called me once because he had trouble and I scrubbed and helped him probably 50 cases later in a more complex case. But so I think putting a number of cases that you need to master something depends on how you learn. And my recommendation would be to see a lot of cases. There's a lot of videos. I put 50 full-length videos online on YouTube. And I guess you can learn a lot about the procedure when you do that. You have simulators. I think simulators might be useful at the beginning, but not yet helpful, like you've done 20 cases and then you would spend some more hours in the simulator and this will help you. This doesn't work like that, sadly, yet. But it's good as a beginning, as an initial contact with the laser. So if you watch videos, if you understand the procedure, or put it this way, HoLEP is easy to do. It's difficult to understand. You need to understand it first. And then once you understand it, and you understand all these factors that I told you about how to use the energy to get the effect you want, and if you're able to master this energy, many times you can dissect the plane with a very subtle effect that is not dangerous, and then if you deepen a little bit in the capsule, you have a lot of time to recognize and to take, move your fiber a little bit closer to the adenoma to get a good plane.
Excellent.
So
another question, please.
Go ahead.
Hi, Fernando. It's Ben Dreyer from Scotland. Nice to see you. Are you started any ejaculatory sparing enucleations yet, or any desire to do so?
Well, my problem with the minimally invasive approaches is that they're minimally invasive, but they have a price. They come with a price. You might preserve ejaculation, but then you'll have to pay another price, and this is usually reducing the durability of the procedure, maybe compromising the future. So I do, of course, bladder neck incisions, and I stop 1 centimeter on top of the vero for the younger patients who want to ejaculate. The Marion syndromes or the bladder neck stenosis, And then I do sometimes middle lobe enucleations, trying to preserve the apical tissue. But I think it's very interesting. I thought, I heard Peter Gilling once saying, we are the only surgeons that remove a benign tumor partially. And it's not true. You know, there's some ENT tumors that are removed partially, because if you remove them totally, maybe you cause a problem that is untolerable. So I think it's a nice avenue. My patients are usually very old. They have huge prostates. So I haven't, you know, even too deep in other strategies. Some surgeons are publishing strategies that seem to preserve ejaculation very well. I think probably for that, the thulium lasers having a much better cutting effect allow you to tailor a little bit better to do the sculpture, you know, to sculpt the prostate the way you want and preserve what you want exactly. With a holmium, it's more difficult because this explosive effect is not so good for cutting. It's very good for dissecting, but not so good for cutting.
Excellent.
So,
Thank
but
you
it's very, very interesting. I think we will end up understanding much better which patients are good candidates for ejaculation preservation. We will understand much better what happens over time. And then we will, you know, we will have a, but I think it's probably better to try this avenue where you remove a lot of tissue with minimal risk for the patients. They go home and they have a debulking procedure than all these, you know, minimally invasive options that need more time to work, or like resume, or you put the staples inside. So when you do HoLEP, you're so wonderful. I mean, how do you say that? My English is getting rusty.
Your English is very, very good.
No, I don't find the words. You get so happy. You see the happiest patients ever, and then you know, you get a little bit lazy trying to settle with a worse, you know, results in terms of functionality. I see patients 10, 15 years after enucleation, and they tell me this is the best thing I did in my life. And so try it. If you haven't done HoLEP or enucleation, this is really worth learning.
Excellent.
And of course, I want to thank you all. No, are we finishing?
Sorry,
or
there's another question, please, Fernando.
Go ahead,
we
go
have
ahead.
your audience.
I think you
I know you probably want to go and have dinner.
Clearly,
but over to you.
My point was, in what percentage of patients can you preserve ejaculatory function following holmium laser enucleation? How do you counsel the patients?
Well, in these cases, mostly all of them.
What percentage of patients do you tell them that you can preserve the ejaculatory function? So let's say, is it 10%, 20%, 30%?
Well, if we try an ejaculation preserving procedure like removing the middle lobe only and cutting 1 centimeter over the vero, I think the success is very high. Or if you do a bladder neck incision, as I said, stopping 1 centimeter over the vero, it's nearly all patients ejaculate. It's quite rare that you have a retrograde ejaculation. But of course, I don't have a general. I mean, normally I try to talk them out of preserving ejaculation rather than, because I have done these attempts in the past, and I have seen these patients over the years. You know, even one of my brothers, you know, he wanted to ejaculate. We removed the middle lobe. 5 years later, he said, "Please take the prostate out. I don't sleep, you know, at night. I'm not happy." You know, ejaculation is if you count the seconds. And then, of course, industry has convinced us that ejaculation is super important for men. And I don't disagree that some men find it very important. But when you tell them this is the balance, you know, this is the real balance in the sense we can preserve ejaculation, you will ejaculate for 3 years. In 3 years' time, you will be again experiencing, you know, urgency, dysuria, you will be on medications again. Or we can do this, you know, you want to ejaculate, but it doesn't mean that you don't have erection. It doesn't mean that you don't have pleasure. You know, your wife is going to be very happy because you don't spoil the sheets, you know, on the bed. You know. All these things are important. And, you know, for the 60, 65, sometimes if I ask them, would you like to ejaculate? He said, yes, I would, because I haven't ejaculated for the last 5 years. So I hope you.
So I'm
forgive me.
I'm mindful of the time, Fernando. It's 9:45 with you.
No,
I
but we
just-
have more time if you want. I was
just,
thinking.
unless there's any more questions, if there isn't, I think we can draw this to a close. So, Fernando, really appreciate you as always. Round of applause, please.
Thank you very much. Thank you very much. And all the best to all of you. And if you
Yeah.
ever want to come and visit us, just drop us a line and I will be happy to host you and try to share all I know with you.
Amazing. Thank you so much for your time. It's been a wonderful case and a great demonstration. Thank you.
Thank you,
Excellent,
Fernando.
excellent moderation. Excellent moderation.
Thank you,
as well.
Fernando, for your time. Excellent.
Thank you. All the best. Bye-bye.